It's a pleasure and an honor for me to discuss heart rate, which is something I've been focused on for the 40 years plus I've been in cardiology. This is a study we presented at the heart failure meetings previously, and I updated further, and it's in a pending publication. No, press this is the one to press. Okay, these are my disclosures. First of all, I want to remind you that the use of beta blockers is very well established in the treatment of heart failure, and however, in this meta-analysis by McAllister, the dose of beta blocker was not of significant importance, but the actual use. However, the heart rate, the change in heart rate induced by the beta blockers was very important. So for every 5-beat decrease in heart rate, there was an 18% improvement in survival. So very important to reduce heart rate with a beta blocker. We showed that heart rate, elevated heart rate, is important. This was the placebo group in the SHIFT trial, which was very well treated with a background beta blocker, and the lowest heart rate in the inclusion criteria was 70 beats per minute. So for heart rates above 70, there was an increasing risk of the cardiovascular mortality or heart failure hospitalization, as well as the individual components of that, as well as death from heart failure. So elevated heart rate in sinus in people with heart failure and systolic dysfunction is a risk above the treatment with a beta blocker. Ivabradine is an agent that lowers heart rate with a completely different mechanism than a beta blocker, because it affects the ion channel, the IF channel that are present in the sinus node, and increase diastole, and by that lowering heart rate. So it's different mechanism, which makes it very interesting to pursue the importance of this agent. Now, it was studied in left ventricular dysfunction in the beautiful trial. These people had at least a heart rate of 60 beats per minute, LV dysfunction with an ejection fraction below 40, and with a documented coronary artery disease. However, the primary outcome in this trial, which I was not involved in, was completely neutral. No effect of this agent. However, if it was looked into, separated only for those who had a heart rate at least 70 or above, there was a significant increased risk for all these components of the primary outcome. So heart rate above 70 was obviously associated with a significantly higher risk than having a heart rate below 70. The SHIFT trial was a trial in heart failure. Patients with symptomatic heart failure, a reduced ejection fraction, and at least 70 beats per minute or above, and in sinus rhythm. And it's important to remember that these patients had also been admitted to hospital within the last year for heart failure. They were randomized to placebo ivabradine and followed, and the dose was up titrated, which is not the important part of my talk here, but the primary objective was met, and the primary composite endpoint was met and was reduced by 18%, and the primary and secondary outcomes are listed here, and they were all beneficially influenced, as was not all of them were significantly reduced because the trial wasn't powered for this, but it was a consistent benefit by lowering the heart rate. So heart rate is important. And to summarize that, in patients with systolic dysfunction, resting heart rate in sinus rhythm has been demonstrated to be associated with increased risk for morbidity and mortality. And I showed you two studies that could demonstrate this. So, and resting heart rate in these patients with at least a heart rate above 70 is associated with improved outcome. I won't go into the details of that. However, whether or not resting heart rate retains the risk association over time and whether repeated measurements can improve it is incompletely known. And international guidelines do not discuss this important clinical issue. They just talk about heart rate as you measure it once for lifetime, so to say. And we use the pooled data from the patients treated with placebo in the beautiful SHIFT studies to evaluate this association. So the prognostic value of repeated heart rate measurements were based on the EKG measurements, and we used the outcomes, cardiovascular death or heart failure hospitalization, cardiovascular death or MI hospitalization, MI, heart failure hospitalization, and cardiovascular death. And we used an updated time-varying analysis. That is, we used the previous heart rate measurement and updated that, adjusted for predefined variables that we knew would affect outcome. So it's the statistical model, which was handled by Ian Ford in Glasgow, was also fitted for adjusting the baseline heart rate and for the heart rate immediately prior to the last previous one. So what we essentially did was we took every visit and looked into the prognosis during the subsequent follow-up, and then saw how heart rate could predict that outcome. And this is the summary of the baseline variables. And for the pooled beautiful SHIFT, those were 8,700 patients, and very well treated with beta blocker, ACE inhibitors, ARB, and in particular the SHIFT trial, 60% of the patients had an MRI on board. So these are the main results. First of all, that there was a continued risk associated with an elevated heart rate. The dotted line here represents heart rate of 70, but it's, as in the beautiful population, there were also people with a lower heart rate. This is represented here. But you can see for all these outcomes, there is an increased risk with an elevated heart rate at the last measured heart rate prior to an outcome over this trial period. And I would say even more important is it to look into what by a quantified increase. So this is the repeated heart rate measurements per 5 beats per minute increase. And so this is the black dot is represent the baseline value, and then it's repeated only in red, repeated adjusted for the baseline value, and repeated just values for previous measurements. And as can be seen, for every outcome, the repeated measurement increase the prognostic information for subsequent outcome. For example, for the cardiovascular death or heart failure hospitalization, the baseline prediction per 5 beats was 13. It increased to 18 in the last measurements prior to an event. And adjusted, it was 17 and then 16. So, and that was consistent across all these outcomes, emphasizing the importance of measuring heart rate. So in comments to these findings, resting heart rate in patients with systolic dysfunction is associated with subsequent cardiovascular outcomes and death. The risk is maintained with the repeated measurements of resting heart rate, even after adjusting for the baseline or immediately previous measurements. There are remaining questions. Does the prognostic value of the baseline heart rate decline in predicting events over longer follow-up? An incremental risk for increasing heart rate, in this for hospitalization or cardiovascular death, which was the primary outcome in each component trial in the SHA-MC program. And this is the change in heart rate between the last measured value and the previous value. So one can see that a decrease in heart rate is associated with a decreased risk for a subsequent outcome, while an increase in heart rate is associated with elevated increased risk, and which supports what we found from the pooled analysis from SHIFT and Beautiful. So the clinical implications based on these two large analyses is that resting heart rate should always be assessed when patients with systolic dysfunction are evaluated. And I would encourage, and I am glad that Professor Ponikovsky is here because he's chairing the next guideline committee, and encourage them to take these data into account when international guidelines need an update on this important clinical issue. So when resting heart rate is elevated, then you have to consider to lower it, and that's another story to discuss in what way it should be lowered, but the increased risk is there. Thank you for your attention.